I have been in public health nurse for over 30 years now, and I just love it. And I always say that they're never going to get rid of me out of public health because even though I teach at UBC, I still keep my hand in practice, and I still then stay on a casual roster with Vancouver Coastal Health, working in maternal newborn program, a Healthy Beginnings program, which is a program where when women have families have a new baby, they come home, and we then follow them up in the home to make sure that they're settled and everything is going well. And if they have any problems, we do home visits. So I kind of pick up occasionally a shift on the weekend there, but otherwise then I'm full-time faculty at the UBC. But that passion of public health has stayed with me, driven my career, I would say, over the years. And I think the key piece for me is it's very upstream. It's about upstream thinking, prevention, protection, health promotion, building the client's capacity, building the population's capacity to begin to address their health issues. So taking that World Health Organization holistic look at what health means and really beginning to address and work with the community to address what the needs are, what the challenges are, or what kind of reorientating of health services we need to do. And so that's where my career has been mostly focused in over the years, doing many variety of projects and initiatives. But coming from that, I think, foundation of really service, wanting to be of service, really wanting to be building the community's own management to manage their health. Any questions on that? Yeah, so very interesting in terms of pandemic planning and to watch what the numbers are like and what's happening, because I actually for the last 2 Sundays have gone to work in the public health unit, and I'm in Richmond, so it's a fairly, a city, but it's not a huge city like Vancouver, but in both areas we already have had right from the get-go lots of planning going in. And when Heather and I were there at the Richmond Health Unit, already lots of planning was going on around in terms of prevention, protection of the population. And now they've got 2 teams set up contact tracing. So right away, when there's an outbreak, public health nurses usually their mandate is right away to begin to phone those places and folks and people where there's been an outbreak and begin to follow up with all their contacts to notify them that there's been you were in contact with someone who had this, and then begin to teach them what to do and when to then seek intervention. And so building again their knowledge and capacity to manage their health and have control over that. So giving the power to them to be in control of that. And we know that when people have power and knowledge, skill over their own health, they're actually much more stronger and much more healthier. So that's always the focus, is that the first mandate for public health is communicable diseases. That's where our focus has always been. So whenever there's been an outbreak, we are always then in public health, shut down many of our other programs and become focused on that pandemic control, communicable disease control. So over my career, I have worked in the H1 and outbreaks. I worked in the SARS clinic when SARS first happened. I actually worked right in the clinic itself. We had set it up on a parking lot, the medic tents, and people came straight from the airport to that medic tent. And then as a nurse, I would be then assessing them, beginning to see if they actually had that, and then beginning to create plans. I did a lot of phone calls at that time, contact tracing plus quarantine, checking up to see how they were doing and whether they needed to come into the hospital or were they managing okay at home. When the H1N1 broke out, I worked in the clinics, plus organized and did a lot of health education for the nurses who were going to work in the clinics. So over my career, I would say I've kind of I think this is my about 5th pandemic that I'm involved in, and so feel real comfortable with it in that way, that I know what are some steps, what will be happening, where we're going, and I'm really grateful for our public health, because I think we are faring really well considering everything. Yeah. So disaster preparation, we definitely talk a lot about that. And again, when I worked in public health, we used to have a lot of health education that would happen even for the public health nurses as a continuing education when there was a concern about some disasters coming up, to build their knowledge and capacity and begin to look at that. And so really, I think that it's really important that we have a very strong communicable disease departments, and we do in Vancouver Coastal Health or in BC, and I think across Canada we have very strong. So if you haven't had a chance to watch, I highly encourage you to watch our Medical Public Health Officer of Canada, which is Dr. Teresa Tam. And so she comes on regularly on the TV and does talks. She's amazing. And then each province has their own medical health officer, public health officer. And for BC, it is Dr. Bonnie Henry. And again, I think she's really fabulous, amazing in her knowledge base. And so she comes on daily to talk to the public and give, let us know where we are with our outbreak numbers, what the plan is for the day, the week, constantly really advising the public what we need to do in order to flatten that curve. And so I think she's begun to have that great relationship with the public. They believe in her, they trust her, and they listen to her. And I think many of us wait for her to come on the TV every day. She usually comes in the afternoons and does a talk.
Yeah.
Go ahead.
Oh, I was going to just do a quick comparison. It's very different. I don't know if you all have experienced any of the briefings in Canada, but it is really valuable to have that physician presence or that medical presence. I know that a lot of the briefings from a national level, they have Dr. Fucci and Dr. Birx, and then more governmental, political, and then the state it tends to be more of the governor. So it's just really, it's a different way of presenting to the, I just find it very integrative. I think it's helpful to have that medical presence. It's
yes.
hearing from the experts, so to speak, from,
yes.
those
I think it's very crucial to have that medical health officer and then them working with the teams, right? So each city has their own communicable disease control teams, and then they work through that, then plus the medical health officers that are usually assigned that each city has. And so then they work with them. So it's very, I think, definitely different, because I watched now some of the American news and what goes on, and also in terms of politicians having to be engaged when they don't always understand all the knowledge and pieces around them, with the outbreak or the way the virus works, and sometimes the way that then they advise in the public, it's very mixed messages or confusing. And when you are already scared and worried, then sometimes these mixed messages can really create a lot more fear and cause more harm than good.
Yes. Yeah.
Yeah. So I hear some of you folks have written about how people being isolated. So yeah, you can go online. Just the CTV is one of the places where they come on every day. And again, the president, just like you folks, President Trump comes on for us. The Prime Minister, Justin Trudeau, comes on every morning. And again, not to put anybody down, but it's very interesting to watch the way they handle the things. So, President Trump gets into the involvement of a lot of the medical stuff. For the last 2 days in a row, people have been asking Justin Trudeau about the mask issue, trying to corner him to say what is his opinion. Should people be wearing masks? Shouldn't they be wearing a mask? And I thought he's handled it extremely well, because each time he has said, I'm not a medical person. It's not for me to say. You need to then be listening to the advice that Dr. Teresa Tam is giving you, the public health, medical health officers are giving you, and follow the advice being given to you by them on this topic. And so he basically has constantly, whenever the medical pieces come, rather than making it very confusing or mixed messages, just says, that's not my part of the work. This is theirs, and therefore they will then guide you and listen to them. And I thought he did that very nicely in terms of handling those pieces. And so I would encourage you to look at, and again, if you're looking for some amazing women leadership, I would encourage you to watch these two women. So Dr. Bonnie Henry, he's the British one, British Columbia medical health officer. and then Teresa Tam is for all of Canada. And there is powerful women, the way they run these briefings. Just think of them. Dr. Teresa Tam is now in charge of all of Canada's public health and managing making sure that we all come out really healthy. And she's yet very calm, very collected, answers the questions with real clarity, but not going all over the map and confusing it. So it's very interesting to watch and I think great role model for those of you wanting to go into leadership. I would encourage you to watch their briefings and see how they handle these everyday media conferences that they have. Yeah, so I would just put their names in: Dr. Teresa Tam, and then Dr. Bonnie Henry. Yeah, so those are the ones that manage the Pacific medical briefings, is actually the medical health officers. So the politicians don't get involved, except trying to be each province say, where we are in terms of supplies or medical stuff that sometimes comes up, but even then it is the medical health officers who are coming up. So I think I've kind of gone off tangent maybe here. So what was our next question, Heather?
Yeah, and thank you for that, because I think, really we can do this, but ultimately, even getting started, there's an elephant in the room. There's this pandemic. So it's really important. This is a huge piece of what we're learning in population and public and community health. So thank you for covering that. And in the meantime, if any of you have any further questions around that, please feel free to ask those as well. So I have another question, and this may be short, but why you came to public health after kind of that experience with acute, and then what keeps you in public health as your focus specialty?
I think, again, it is that focus on the prevention. So really, I think that's the key piece to me. This is where we do need to be putting the money in, is looking at preventative services. And again, really then working with the populations to help them address their health issues and take ownership and begin to be working how to teach them to stay healthy. And I think that's the upstream piece that for me is very important. When you've ended up in hospital with some of these chronic illnesses, it's too late. So we need to be really working at the front here. And so I think that's the piece that's really kept me, is the opportunity to work with different population groups to help them build their capacity, take power, and begin to be addressing. So, really having the opportunity to reorientate health services. And I'll give you a good example of this that took place in many years ago. So a public health nurse worked in one of the public health units, and she used to run a parent-infant group, so a baby drop-in kind of program for new moms, but began to notice, because she could speak Spanish, that afterwards, when she would finish, there would be these new refugee Spanish-speaking people who would want to talk to her. So they didn't have medical coverage at the point because they were refugees and underground, but would want to get some health services by talking to her. And as this began to increase and evolve, then she came to say, you know what, some of these women are pregnant, they're going to be delivering in the hospital, which is going to cost more. So what about upfront, we begin to do some preventative work here and begin to look at bringing some resources together, beginning to do that interdisciplinary community agencies coming together, offering a service so we can do some preventative work so that when they go at the time of the delivery, that these babies are not going to require a lot of services and therefore be very costly to the healthcare system. And so that did happen. For a while, we ran a clinic. It was called Bridge Clinic. And it was a clinic for refugees who didn't have medical coverage. So they were either waiting for their hearings regarding refugee status. Some of them might be still underground and kind of being sponsored, but not yet really, again, granted anything. And so it was public health nurses that would run the clinic. And a lot of times it was mothers and children who would come, and we would do assessments. And then we managed to procure from one of the hospitals that we could use their lab to send some of the stuff there. We managed to get an OB-GYN from BC Women's Hospital to become part of this team. So 1 day a week he would come, and then these women who were pregnant could come there and see an OB-GYN. So it became a team effort, but it became many agencies coming together. So you had health, you had the acute sector, the public health sector, and then we had two community agencies. One of them began to offer the language services, so they would send their language workers over, and that then we would have on certain days a certain population coming, and then their workers would come to help translate and then follow up with any of the appointments that needed where there was language services needed. And then we had another agency take over in terms of helping to find some of those resources. So for some of these families that were maybe needed to find how to register the child in the school, would then begin to help and work with the families to get them set up. So it was very community agencies and the public health and the acute sector coming together to run this clinic. And we ran it for almost about 5 years before then the services were integrated into being in a different way, rather than this very Pacific bridge clinic that was run in the public in a community health center.
Wow.
So that's kind of an example of how you begin to see an issue and then you begin to reorientate health services to say, how can we stop the huge cost over here by doing some preventative work here, right? So it wasn't going to be very costly for the maternity hospital to send their OB-GYN 1 day a week to us to help make sure we could do some of that preventative work, for the public health nurses to teach prenatal. It was not going to be an extra burden, whereas it might be a very big burden if they hadn't received those services and show with a lot of health problems at the time of delivery and just showing up at our door and needing that service. And again, in Vancouver, Canadian healthcare system is very different. So we don't turn anybody away. We still have them. We would still be then offering the full medical care in the hospital, regardless of whether they have medical coverage or not.
Wow. Thank you. Yeah, it's as one student nurse mentioned about public health, experienced it for the very first time. She said it's such a dynamic experience. I mean, public health is dynamic, and you've really showcased that there, and just all of those stakeholders coming together. And when you get more people around that table of innovation, you're able to do so much more. So, yeah.
Mm-hmm. And I think it also demonstrates that as public health nurses, we do have the power to be able to make those changes. Sometimes it can be daunting and feel that, okay, you're seeing this issue over and over again, but what can you do? But I think that it's important for us to realize that we do have, sometimes it takes a long time. So community development work, I feel, takes a long time. And sometimes it can be frustrating because it seems like you do 2 steps forward, 1 step back. But over time, it can lead to some amazing sort of initiatives, projects, and ways to then do that upstream nursing, upstream healthcare that is so important to keeping our healthcare dollars and budgets contained.
Yeah, and the quality aspect as well, preventing those potential situations with a newborn baby. In that example. So, third question: you've been awarded the High Distinguished Nursing Excellence Awards provincially and presented internationally at conferences. You've shared one of the projects. Can you share a little bit more about the other projects that you've been a part of, specifically with student nurses?
Sure, yes. So a couple of big ones that we've had. That's kind of just, again, from looking at addressing what's the needs of the community. So I think one of my key things always is to work with whoever the community is and see what their needs are, and then looking for ways to address. So as you know, in Vancouver, downtown east side is where a lot of our homeless population lives. They live in a lot of makeshift tents from sometimes cardboard and tops. And there's a couple of agencies that then provide meals to them. One of them being the Union Gospel Mission Church, and it's not actually church, but it's the center where they run the 12-step addiction program. They run meals 3 times a day, and they serve anywhere from like a couple of thousand people in different time slots. And so one of the things that they had, and we had been a couple of times near them and had some talks with them about us bringing student nurses into this area and wanting really to build their knowledge base and their comfort level of working with vulnerable populations that maybe they wouldn't see on a daily basis and have had no experience. Lots of fear always, right, about working in the downtown east side or where we have some of these vulnerable populations. So one of the things that had come up from them was about feet, so foot care. And so one of the things they had the concern was, especially in the rainy winter months, when we have many, many months of rain and these people are out there walking about with soggy, wet feet all day, but wanting to somehow find some resources around foot care for the clients. And so what we decided to do was that us using our student nurses, whom we wanted to get to build that comfort level, begin to build their relational, skills in terms of communication, learning to build that trust with populations. How do you do it? And beginning to hear stories of people that maybe hadn't always been homeless and poor, but had led their circumstances and get a real sense of how quickly that can happen sometimes to folks. We decided to run foot soak clinics. So the student nurses would then come once a week, and during the meal, just before the meal time, we would set up about 8 stations with basins and all sorts of stuff, equipment to run a foot soak. And so the client would then soak their feet. And while they were soaking the feet and sitting, the nursing students would connect with them and talk with them and try and do a bit of that assessment, where they were in their lives, what were they connected with resources, what kind of service did they need need any help. And after the foot soak was done, we always then gave a brand new socks. And if they had any problems with their shoes, then between UGM and us, we would try and help find some new shoes and stuff, and then be sending them off. So we ran this on a weekly basis, and we continued to run it. And it started, I think, in 2014. So it's been 6 years that we've been running this foot soak clinic at UGM. And so it's been a great partnership with UGM, great partnership with us in terms of our students learning to be working with vulnerable populations, being in areas that they would never otherwise maybe visit. I remember reading, and we would have a journal that they would write some of their reflections. And I remember reading a couple of times some of the journals that students would talk about. I had never been in this part of town. I lived on the west side in a very rich area. I've never had any knowledge or notion about this population. And what the surprising thing for me was that they're just like us. They're people just like us. There's no difference in that. And beginning to realize that sometimes, yes, the circumstances can cause people to become homeless, become poverty-stricken, and be living in these makeshift tents, but yet they are the same as who my family is, which is very eye-opening for young people that are just beginning their nursing careers and yet, haven't worked out there and haven't had a lot of contact with populations that are very vulnerable and have lots of challenges in terms of social determinants of health. So that was one of the big things we did that has continued to do. We began to have very popular with the population that came. The UGM calls their clientele guests. And so very popular with the guests that would come. We would have a wait list sometimes. There sometimes could be quarrels because if somebody thought somebody jumped the line for the foot soak. So we had to set up a system of how to make sure that it was very done fair and square so that nobody got angry or upset. As you can imagine, folks who have sometimes mental health challenges can be very easily triggered. And so we had to be really careful. And the other things we had to learn about was in our students was how to then learn about their own management of staying safe, setting boundaries, and protecting themselves also. So it was about safety also learning, but also learning to work with populations. And then as time went on, this partnership grew stronger and stronger. And so one of the things they asked us was, sometimes we have people that come into our center that we think maybe are under the influence of substance use, but have a couple of times realized they were actually having a diabetic reaction. So they were having hypoglycemic attack, and we didn't pick up that cue, and have had some really risky situations. And we have volunteers who run these programs. So could you help us do something about building the capacity and the knowledge of our workers, our volunteers, around being able to identify? So the other next project that we did was where we actually created, the nursing students created an online module as part of their orientation for all their volunteers and their staff, to be able to then have this online module they would do before then they would begin to work in the field, giving them what are signs of hypoglycemic reaction, what do you do? And we actually then created a couple of safety kits for them to be able to use and keep in the center, so that the knowledge was there and where to find the kits and what was in them. So all the usual things that you might have in a diabetic reaction kit was then created. This was very popular. They really found it very helpful. And in fact, one of the things that one of the workers told me was, no sooner had we done that kit and done that module, they actually had someone who ended up going to the hospital, and they were able to pick it up quickly because from that learning, and that person then was hospitalized because they're actually having a diabetic reaction, hypoglycemic reaction, and were saved in terms of their life. And so from that, a couple of the other agencies in the community heard about it. So it's kind of a ripple effect. So some of the other agencies that serve some of this vulnerable population asked the nursing students if they could also create, or could they have copies of that kit and copies of what we had created, so that they could also do the same for their agencies. So that's an example of that ripple effect. Building capacity. We're not going to be able to go and do their orientation every time, every week, whatever. Building their capacity of an agency to manage that themselves by building their knowledge and of the workers to be able to keep their clientele safe.
And Ranjit, there's just been some conversation just in regards to vulnerable population. And since you've been down in the downtown east side, as I have, just in regards to the vulnerable population right now with COVID, are you aware of how that the homeless population are doing down in the DTES?
So from what I know a little bit of it, I haven't been recently down there, but I know that it's been discussed on the news. There's been some discussions, is that there are actually, the outreach workers are working there. There has been discussions about housing them into single occupancy hotel rooms. So that would be the only way to really create that social distancing. And so there have been discussions about beginning to do some of those initiatives. I would think that some of these agencies are also looking at how they're managing. I do know that they've stopped doing the meals that the way they used to do them. Before, the meal was in a kitchen. It was like a dining room, cafeteria style. You came and had trays and dishes, and people served you, and then you sat down in a group and ate. Now it's not. It's more in portable takeaway kind of containers, and they're made and this put on the table, and clients come. Those guests come and pick up that container and take it away and eat it in whatever place they are at. So that social distancing is continued to be practiced. And so they've had to relook and rethink how they then are continuing to provide the meals for the vulnerable populations. There's been a big ask for volunteers to come and help at the food banks. So my students have in the past also worked at the food banks, where we have ran sometimes hypertension kind of screening clinics, or diabetic screening kind of clinics. And so one of the asks has been, because we know it's usually more your elderly population who volunteers in the food banks, packing and having all the food for the client to access, that we need younger population now to come and help be packing the bags, which are then being distributed rather than people coming to collect. That can we then be looking at young population coming who have a lower risk around the COVID versus the elderly population.
Yes, yes, thank you.
So rethinking all of it in terms of then managing the pandemic, who's your population you need to protect, and then how do you continue to keep them indoors and practice that safe distancing and keeping them healthy.
Yeah, and then on top of that, that whole aspect of a lot of the homeless population have such a strong community support within their own culture, and then the mental health on top of that with the social distancing is difficult.
Yes. Yeah, and I think there's been lots of discussions about the mental health and what we're going to see during this pandemic. We're just beginning, so as time goes on, what will this mean?
Yeah.
Not only for the vulnerable population, which is going to be high already, as you said, because of that community, but just generally all over for all our different population groups. But definitely there's been discussions about the resources coming out more into the downtown east side to be then helping with the vulnerable populations, and some of the agencies that serve them, how can they begin to then look at reorientating themselves as to how they provide that service in a different way.
Yes. And just on that thread of vulnerability, you created the Social Pediatrics Community Health course that addresses vulnerable population and the pediatric population for the BSN accelerated students. I've read and seen how highly successful it's been, and many of the BSN students have really gained so much knowledge that they wouldn't have had if they just had clearly just an acute experience. And based on that, many of them have gone on and become public health nurses because of that. What motivated you to develop this opportunity for learning in the side by side with the acute opportunity and promote this to the UBC School of Nursing?
So again, social pediatric has been around for a while, but it has begun to become much more bigger focus. So McGill actually now has a course for their pediatrician physicians called Social Pediatrics, and it's a full course. Back in Quebec, Dr. Julian is the one who is a founder, and he's still alive and runs a couple of clinics out there that began to then talk about social pediatrics, where we are then looking at the social determinants of health that are impacting that family, and also the health issues, and combine the two together. And back in 2005, actually, I happened to have an opportunity to be in Quebec and go and visit his clinic and go and see him, and I had heard about it. So then I think it was in 2006, I kind of brought the idea to UBC. And then actually we began to do one of the faculty members, and I wasn't faculty at that time at UBC, but one of the faculty members took it on as actually a research initiative. So I would encourage you to look at what's called the RICHER. So that's the acronym name for it, is that the research then began to happen in BC, geared to the BC population, and so looking at the vulnerable children and what are some of the needs. And so it began to be situated in the downtown east side again, where then we do have young families with young children with lots of health issues, many families where the parents have a lot of mental health challenges, substance use challenges, and then you've got these young children that are then still under being cared by these families. So she set up a big committee that has been doing social pediatrics, but it didn't really come fully into our program. And so there was one kind of, in terms of nursing students, one little clinic that we would run around in terms of social pediatrics in the downtown east side at Raycam, and Tatiana, so she was would be the nurse who would have about 5 students, and the rest of the students didn't always get a chance to do it. And then there was an opportunity to expand it back in 2017, and that was when I was the course leader. So that's when we began to expand it, look at giving that opportunity to nursing students to being with children, and the Strong Starts are the program that our nursing students are based in, and Strong Starts are situated where we know that high-risk populations are, and especially children who have very high risk in scores in terms of the early development screenings that they're showing high risk. These Strong Starts have been situated in those places to try and then help families who have children who might be at high risk to help succeed. It's called Success by 6, help to get these children ready so that when they come into the school system, they can succeed. And so that's what the whole initiative for the government is, that the strong starts. And it was perfect because then we could bring our nursing students to begin to be, and it's public health nurses who serve these populations in the strong starts. They are our clients. So for public health nurses, it's not just the one-to-one client, but our agency is our client, the school is our client, the Strong Start program is our client. So that's our patient that we would serve. And so public health nurses do serve Strong Start. They're all usually assigned a nurse to them. And so this was a great opportunity to bring our nursing students in, learn about pediatric population, learn about assessments, doing in the community assessments, and then learning about the public health program. And so having this kind of three-pronged learning happening at the same time about the public health program and all the services they provide, learning about them in terms of how does the, what are some initiatives that we have by the government being taken on to make sure that the population does succeed and we continue to produce a very healthy population when they come out of school, go into their careers, that we have population that is strong and viable. And so we do know that early childhood is one of the social determinants of health, of how well you do in terms of success, and in terms of then looking at economic and well-being, that plays a key role. So then these strong starts has been great, but it's been great for our nursing students to be able to come and learn again that social determinants of health. How does that play in the early childhood development? What can we do preventatively? And so the ACE studies, in terms of the adverse experiences that children experience, they learn about that, and they learn to do how to do assessments in the community. So doing assessment in the hospital is very different from doing an assessment in the community. So many of these students sometimes are applying to go on also to be, as you said, in public health or become nurse practitioners. And a lot of nurse practitioners here in BC work in primary care clinics, where then they will be coming and doing assessments in the community health centers, in our public health units, or in the primary care clinics.
Excellent.
So that's how it all came to be, was the need and what were the resources already well set up for us.
That's excellent. Thank you. And moving on, just in regards to the work that the students will be doing at Western, is we'll be covering community assessments, windshield surveys, asset mappings. Can you share a little bit of your expertise around this and the importance of this in a BSN program?
Sure, yes. So when we have our students in this community rotation, we always have a couple of pieces of a couple of our lectures very much focused on learning how to do community assessment. So as I said before, the community is our client or patient. So, whatever that community setting is, that's that patient. So just like doing a needs assessment or assessment of your patient in the acute sector, you need to do an assessment of your client in the community. And so one of the important things is then beginning to think, well, how am I going to assess that patient, which is your community, and beginning to then look at ways to find some of that data. So one of the first things I always have the students do is go online and do a lot of data, looking at a lot of the data. So going online, so for example, now Richmond, begin to go online and look at Richmond city data. What does the city have? What are some of the population data that we have in terms of stats around number of births, number of deaths, the vital statistics, beginning to collect that very easily epidemiology data that is going to help you plan what is it that the health issue for your patient client is, and what are then going to be some things that you will need to then create in terms of program planning. And so creating that big picture of your patient, which is your community, and then beginning to do the second step is what I call leather epidemiology or foot epidemiology, which is where you go out and do windshield walking, right? So walking around and beginning to actually visit the agencies, seeing what they like, what kind of agencies are there, what kind of services are they providing, are they friendly, are they welcoming, who works in those. So really beginning to do a lot of that walking windshield data. So when we say windshield, it is not about just driving and doing a windshield, but it's actually getting out of your cars and getting out of the buses and transportation and walking into these different places and beginning to get to know them. Because if you're going to do any partnerships, any collaboration, building liaisons, then this is the people you want to get to know and know who's out there. So that's the second piece I have the students do. And then the third piece is actually doing some sort of survey or a questionnaire or a face-to-face needs assessment, or beginning to talk to the stakeholders, or setting up an appointment to see a stakeholder where you might be planning to do a project and actually meeting them face-to-face and beginning to collect data from them. So for example, I'll give you an example. So we just talked about a strong start. So I usually want the students in a strong start to go meet with the teacher and kind of get a sense of who's the population that comes to this strong start, to this program. What kind of a population are they? What area do they situate in? Where is this strong start situated in? What's the setting like? Kind of collecting all that data to get an understanding of what it is your client has in terms of resources and the gaps in the services and needs. So beginning to collect all these different pieces of the data and bringing it together, and then going back to check with your client or your patient that is this what you're seeing, is this what's out there, and what are some programs meeting the needs, but where are the gaps, and beginning to then look at some of those gaps and begin to address. So I think you've shared the art truck example, and that's exactly how that happened. And there was Joyce Henry, the public health nurse, who had a school. So the school was her client, that was her patient, and beginning to look at what was happening. And what she had found was that there were these children hanging out after school, just hanging there, available for sometimes for people to come and, gang-wise to recruit them, or, and just in there with no sort of care afterwards, and began to look at how she could begin to address this issue. It was a high, again, vulnerable school with high population, with lots of sort of children on the borderline of that social mental well-being, and beginning to then think about what could be done to help that school and that client.
That's wonderful. And I understand from that, I've uploaded the article that you had sent about the art truck, but just even based on that, it started very small with just one school, and then the community partnerships expanded and expanded, and then there was food needs that were donated, and so there you have the dietary, that's a part of that partnership, and then other artists came on board, and the municipal city came on board, and then it expanded to other schools. And so it's interesting, again, the innovation and the possibilities of just that one assessment, or that, as you mentioned, the needs assessment, and having those conversations, those vital conversations from one nurse, how that can continue and build. And
so again, very good example of that, as you said, from one to expanding, because then it began to be, I think then the next couple of years, it was like 3 schools, and then the ask was for more and more. And then now eventually it's become a city program, right? So it's no longer one public health nurse struggling to run the program on the side of a table, but beginning to have this, leadership people recognizing the importance and the needs it was addressing, and beginning to be willing to be putting some dollars behind it, and then taking it on. But one of the key pieces that I think I want to also say here is the evaluation is important, right? So doing the evaluation of some of your initiatives. So right away after that first year, she began to then do some evaluation. So once she had a survey that she began to do pre and post after the program. And one of the things what she was looking at is that we do know when children have adults they can turn to, that they are much more healthier in terms of well-being and mental, because that they have an adult that they can feel that they can trust and go to for help. And so when she would do that survey, sometimes some of these young children wrote that they had 0 adult that they felt connected to in terms of an asset, that they didn't have that asset in their world. And so when she would run this program, some of these children that were very, then again, as I said, vulnerable, began to, after the program, would say, I have 3 people that I feel I can go to. So the teacher, now I know her much more comfortable, that was running the art program, or now I know the principal and I feel much more comfortable that I could go to. So they began to identify, and that began to build, and she would do that after each time, each year, pre and post, as the schools expanded, pre and post, and was able to collect that data for a couple of years and demonstrate the difference it made in terms of building that mental well-being for these children. And demonstrate that again, later on, less maybe funds or less services in the mental health, because already we've done the preventative work here with this very easy program.
It just speaks to the importance of that data to substantiate any type of program research, needs assessment. We need that data. So I appreciate you touching on that. Last question before I open it up to everybody is this module, and it's throughout the entire course, and the themes of population, public health, community health, and then the social determinant of health. How do you see each one of them connected to one another, and how do you see each one as separate? As there's a little video that I uploaded, and the speaker speaks of how different each one is. But however, there's just there's really, they are very much connected as well.
Mm-hmm. So again, the public health program that we have here in Canada is very focused on primary prevention. So, right, the prevention before something happens, like the immunizations. Now with this pandemic, we're all madly waiting for a vaccine to come. And so that being the focus of the public health program is protection, prevention, and then the promotion. So the 3 Ps, as I call it, of the public health. And so that's been sort of that piece. But then you have the other piece is the population health. So you're looking at a particular population, identifying what is that population at risk for, what are some risk factors that we do know that we could be for, and beginning to say, then how can we begin to address that? And so one of the examples I can give of that is we, back in, I think, 2006, went to what we call focused nursing. So public health nurses were divided into teams to begin to focus on a population. So you had the 0 to 2 team, meaning the nurses then focused on populations who were 0 to 2 years of age and their caregivers, right? So the maternal program and the postpartum program, and up to, say, 18 months or 2 years of age. And then we had the early childhood team, which would then take over from 2 years to 5 years of age before these children went to school. So all the strong starts, all the daycares were their clients. That's where they did a lot of their work. And so that was the early childhood work, focusing on the early years. And then we had the school team, which worked then from, say, age 5 to age 18. And then we have the youth clinic team. So we had these nurses in these different teams, working, focusing on a population, identifying what we know from the research, are the risk factors, what are some of the data telling us in terms of this population, and beginning to then gear their public health programs and services to then address those needs and prevent them from becoming expanding or becoming escalating, and trying to then do that primary prevention rather than doing the secondary and tertiary prevention. So that's how the 2 really work hand in hand, and we do have it set up. Now, one of the things I always say is, in too bad, in some ways, that public health is considered a very poor kind of sister of the acute sector. And so a lot of the budgets sometimes are cut back in public health. Over the years, we've had cutbacks in our budget. So the 0 to 5, now it's the 0 to 5 team, that early childhood team was amalgamated into one team, which meant that nursing positions were cut and the workload increased for the nurses. So we lost the team that really, really strongly focused on the early childhood. We now work from 0 to 5 and 5 to age 18 months, and then the youth team. youth team. And so one of the things I've heard from nurses now is that because they're not so focused on the early childhood, sometimes because of the number of maternal newborn babies that get discharged, their focus gets to be more there. And sometimes going to their facility, to the Strong Start, to do the child assessment in the early years, sometimes gets put on the back burner because it's not a burning issue right in their face. And so sometimes there's been a concern about, are we doing enough around our and prevention in terms of getting that population ready to be in the school. That's been kind of looked at and considered. And that's why I think if you had seen some of the charts now being what team is around which district, and they are beginning to try and sort of bring that up because that was beginning to be lost because of the changes in the way the teams were set up. So that's sort of population health and public health working together, but yet they're very separate because we also then have at a higher level, the surveillance data unit. We have a big surveillance unit that looks at what are some of the population health issues. And so then we've had things like the CanRisk, which is a diabetic screening tool used. Initially, it was created to gear to the older population because we know that the diabetes in terms of chronic disease is there, looking at the heart disease agencies and beginning to do some of those screening initiatives. So that's at a bigger population level, so it can be done at a very separate level, but yet at the public health, we then are more focused, usually for 0 to age 19, and their caregivers is who we focus on. And then we begin to be, our first mandate is always communicable disease. So when it comes down to now, COVID going on, we really cut back on all those school kind of programs and initiatives that we were trying to do in terms of these primary projects, but now focusing on just mandate of. So that's how they sort of work very together and yet very separate.
Thank you. Thank you. Thank you for all of this this time, Ranjit. And I'm going to just open it up to anybody that has any comments or questions. Please.
And then I didn't look at the chat, so I don't know if there's any questions on the chat.
There was some mention about the ACE scores when you mentioned about the early childhood.
Yes. So the adverse childhood experiences is what it's called. And I would encourage you to take a look at that so that we do know those who've had more adverse early childhood experiences, had the research is showing that later on, they are the ones that are having much more chronic illnesses. And so we do also, from what some of the research is showing, that adverse childhood experiences are more with those vulnerable populations. And so really beginning to look at why we want to be key, doing some preventative work with families with young children where they're very vulnerable, the parents themselves because of their health issues, so that we can prevent or decrease the number of adverse childhood experiences for those children, so that they're not having, when they grow up into adults, having some of those illnesses, those social determinant of health issues continue to impact them. And so I would encourage you to take a look at that. There's a lot of lovely couple of YouTubes, and I can always send you some links there, Heather, where you might have looked at some of that work yourself. But I know in the last couple of years here, we've been doing a lot more education for our public health nurses around that, because they're the ones who then come in contact with families with young children. So how do you build the resiliency of those families who might be at more risk of, in terms of, because of their vulnerabilities, not being healthy enough to raise the child in a loving environment? How do you begin to change that? How do you work with those families that are experiencing mental illness and be able to create the warm, loving environment we want for our children, for the brain development to happen, for the synapses to happen the way they should be, so that that child succeeds in the school, graduates, goes on to be a successful, healthy, adult, making economically, being able to do well, because we know those are all impact how people do in terms of social determinants. So we know income is a factor on how well you do in terms of your health. Education plays a role. The early childhood development plays a role. And so really beginning to look at how can we address these social determinants of health and make sure that the population, when they grow up and become healthy or become adults, that they continue to stay healthy.
Thank you. So does anyone have any questions at this time? So Megan, I also wonder what is happening now with children's being forced to stay at home and not have the school outlet.
Okay, so I don't know if you folks have had this, but in the last several, I would say starting last week, began to be lots of discussions that we're seeing a lot more domestic violence rates going up, right? So there's been a lot more of that happening, and there's been lots of talk about then beginning to provide increased services to agencies that's helped to serve women who experience domestic violence. But that's been a big talk, is that we are seeing our domestic violence rates going up because then it's not safe to stay home in those for those families or for those children. And so there is being extra money put towards, I believe that was on the news yesterday, I believe.
Right.
So again, I would encourage you to take a look at that in your communities and see, is there anything about that going on in your community or being talked about in the media, or what is being done in terms of initiatives? Because in ours, then there's been discussions about increasing the resources and services for those agencies that serve families who have experienced domestic violence, so that they can be beginning to serve, because the number of phone calls are on the rise.
And that segues nicely. Julie, you asked, how do you see the budget in BC becoming increased to take on the new challenges and needs pertaining to the COVID-19 pandemic? And are there currently any movements happening with reallocating funds already? So it sounds like it's occurring in the domestic violence. Are there any other areas that you're hearing are being allocated?
Yes. So one of the big, again, has been the monies from the federal government around even families being supported around finances, right? So many people have lost their jobs, many businesses are being shut down, and therefore there are people who are going to be now, won't have any salaries coming on, and there's been a lot of concern about it. So starting yesterday, people were beginning to be able to fill out forms to apply for funds that have been made available for those who have been hit by loss of salaries. And so yesterday, Justin Trudeau, began to announce, and each date, I think if you were born in January, February, March, yesterday was, and then I think it was April, May, June, then you can go online and begin to fill the forms out requesting funding and demonstrate that you've lost a salary. And there's been funding also allocated for businesses who can demonstrate that they're able to have so many people employed. And then there's funding, I think, to help them, certain percentage of money to help carry the salaries on. So if the employer can pay 80%, I think they can apply and get 20% of that salary from the government to help that person still continue to be employed with them. Lots of also recreative thinking of business is going on. So I don't know how it is over there, but for us, a lot of the takeout has begun to, even though then, yes, our restaurants have shut down, but now they began to do a lot of takeout. And they're actually very busy with the takeout, and the message continues to be help support your local restaurant by ordering some takeout. And so there is lots of talks about people ordering takeout to help continue to support the economy.
That's great. Any other questions? You can unmute and we can hear your voice. I know, Donna, you mentioned about you had something here about you did your policy brief on the Foundry and the wraparound services, or you used the example of the Foundry, and that's a vulnerable population as well.
And I think it's important to also mention that it's a one-stop shop, meaning you can get all your needs taken care of in one place. And I think that's equally important during this pandemic, especially with the rise in domestic violence. I mean, there's, these individuals who I think it's up to age 24 can, maybe have like that extra screening tool and services available to them during this time. So.
Yeah, so we do have some foundries also. We have a foundry that is on the North Shore, and then we have, I believe, one in Vancouver. And then a new one will be opening up in Richmond also. So we have begun to have boundaries, and yes, they will gear to the youth population up to age 24, one-stop shop. I would think that now during the pandemic time, they're probably not running fully, but maybe more of that virtual resources and services, because many of the these kind of programs have been then reorientated to go and help with pandemics. So then it is public health nurses that also work in those, in terms of some of the STI testing and the youth clinic kind of services. And so I know that that's probably maybe has happened, but I'm not sure. So I could be completely wrong. And so even in the public health around the maternal newborn program, we began to do virtual telehealth kind of services. And if someone is really needing the service, then we're asking them to come into the office and being really careful about the use, but yes, using protective gear. But as you know, we are beginning to run a shortage of protective gear. So that's very much being then kept for the acute sector for those who are working with the COVID patients. So that protective gear plays a role into what can you provide in the community and what can't you provide, because then we are needing to have that for the nurses that are working in the acute inpatient sector. But the founder is fabulous, so thank you for bringing that up.
Thanks. All right. Thank you, Ranjit.
Okay,
Really
thank you. Yeah, so feel free to, if you have any question, to let Heather know, and I'd be happy to help or follow up or send anything, links that you might be looking for. And it was great to be here. So thank you so much, and good luck with the course. It's amazing, fabulous sort of populations to learn about. And I would encourage you to really go dig deep in the communities that you live in to begin to gather that data.
Thank you. Thanks, everybody.
Yeah,
what I'll do is I'll just have like a quick informational on a video. So we'll just end the session now. If you have any pressing questions right now in regards to the course content or maneuvering, we can have a question and answer time now. But what I'll do is I'll do a little orientation video with the screen, just what to expect moving forward. All right. Ranjit's left us. Well, thank you, you guys. I don't want to keep you longer than we said. We've got 15 minutes more. So is there anything, and I'm just going to quickly